Welcome, and thank you for joining us for the FOA webinar, Using Information Technology to Support Systematic Screening and Treatment of Depression in Cancer. Before beginning the presentation, I'd like to provide a few tips for using WebEx so that you get the most out of today's webinar. All attendees will be in listen-only mode. Please feel free to submit your questions throughout the presentation in the Q&A panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. Please note questions about specific aims or grant application details will not be addressed. I wanted to note that today's webinar is being recorded and will be posted online at a later date. We also have a feedback survey. Please take a moment to complete that at the end of today's webinar. With that, I would like to pass the presentation over to our speaker, Dr. Gurvanit Randhawa, Officer in the Health Systems and Interventions Research Branch at the National Cancer Institute.
Thank you, Jennifer. Good afternoon, everyone. I'll be presenting the rest of today's webinar. I work, as Jennifer mentioned, I'm a medical officer in the Health Systems and Interventions Research Branch, which is located within the Healthcare Delivery Research Program in the Division of Cancer Control and Population Sciences in the National Cancer Institute. If you wanted to contact me, my email is given below in the slide. In today's webinar, I will provide a very brief background of our division and of the different grant mechanisms that we use. The bulk of my presentation will be on the funding opportunity announcement. I'll give you the background on why this topic was chosen. I'll provide you the goals and scope of the funding opportunity announcements, both of the program announcements, the application dates, and other resources. Towards the end of the webinar, I'll be answering questions. Please note that questions about specific aims or the details of your grant application will not be addressed. So for the first part of the webinar, I wanted you to be familiar with our the Division of Cancer Control and Population Sciences organizational chart. Within the DCCCPS, there are 4 programs. I work in the Healthcare Delivery Research Program, which is the newest of these 4 programs. The other 3 programs are the Behavioral Research Program, Epidemiology and Genomics Research Program, and the Surveillance Research Program. If you want to know more details about our program, the link is given below in the slide. Very briefly, our program has 3 branches: the Healthcare Assessment Research Branch, Health Systems and Interventions Research Branch, which is where I work, and the Outcomes Research Branch. All of these branches work together to advance innovative research to improve the delivery of cancer-related care. Although most of the grants that we fund are investigator-initiated, that is, they are unsolicited, we do support grant application specific areas of interest through 3 mechanisms: through requests for applications, program announcements, and program announcements with special receipt, referral, or review considerations. In today's PA, we'll be discussing 2 grant mechanisms, R01 and R21. I will not go through the details here. The details are given in the chart, and if you need more details, then please feel free to contact me after the webinar. For the funding opportunity announcement, which is, there are 2 PAs, PA 18-493, which is targeted on the R01s, and the PA-18-492, which is targeted on R21s. Both PAs are under the same title, Using Information Technology to Support Systematic Screening and Treatment for Depression in Cancer. The reason we wanted this topic and for the program announcement to solicit new grants is that depression is a big burden in cancer. It is thought to be up to 24% of cancer patients have depression. The depression decreases quality of life and increases risk of suicide. It also decreases adherence to treatments, all of which contribute to increased risk of mortality in cancer patients. Depression also increases healthcare utilization and costs, so it is also of interest to the healthcare delivery organizations to better manage depression in cancer patients. Screening for depression is recommended for several reasons. One, we have several instruments that can accurately screen and diagnose depression. We also have many efficacious therapies that are available to treat depression. Consequently, both the U.S. Preventive Services Task Force and the American Society for Clinical Oncology have issued guidelines that recommend depression screening. The USPSTF, in addition, notes that there should be systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up of the patients. We also have an effective care delivery model called collaborative care that works in depression. Collaborative care treatment programs coordinate the delivery of interventions across a multidisciplinary clinical team. In the case of a cancer patient, that team may comprise of a nurse, social worker, psychologist, oncologist, psychiatrist, and a primary care provider. The care manager or the care coordinator, who is the hub of this delivery model, is often a nurse or a social worker. In some models, the psychologist is the coordinator. It has been shown by many studies that collaborative care-based programs are effective in treating depression, not only in cancer, but in primary care. I have just given you one citation of a recent study on cancer patients, but there are numerous other studies that have shown that collaborative care-based treatment programs work and are effective in a variety of settings. However, collaborative care is resource-intensive, therefore it is hard to implement in routine practice. We know from several studies that depression is poorly managed in routine oncology care. There are studies that have shown that in the absence of systematic screening for depression, oncologists underdiagnose depression. We also know that depression is undertreated in cancer patients. One population-based study showed that 73% of cancer patients with depression did not receive any effective treatment. A more recent SEER Medicare study showed that 27% of older cancer patients with new depression received no treatment. There are several barriers to the delivery of depression care, of which we have highlighted three that are the grounds for the FOA. The first is a shortage of mental health providers, especially in rural states. For example, Idaho has 1/5 the number of psychiatrists compared to Massachusetts, and Mississippi has 1/10 the number of psychologists compared to Massachusetts. There is also a difficulty in coordinating care amongst various providers that take care of the cancer patient. And we know that because of limited time, there is inadequate time for patient physicians to communicate effectively, which is essential for both screening as well as counseling to treat depression. The recent advances in information technology have enabled us to think about many new solutions to delivering care for cancer patients that have depression and to improve the delivery. One example could be using telemedicine to connect mental health providers in academic centers to community oncologists. Another potential solution can be developing new clinical decision support tools that are easy to use and useful to improve the coordination of care. Another delivery solution may be developing patient-facing apps to help with the care coordination. And a fourth one could be using clinic-based mobile devices or computer kiosks in the clinics to conduct depression screening. These are just examples that have been listed in the FOA. One can easily come up with many different solutions. And so one should not be limited by just looking at these as the only solutions to suggest or to work on for responding to the FOA. The goals of the PA-18-493, which is asking for R01s, there are 4 goals here. One is to identify new information technology-enabled delivery models to screen and treat depression in cancer patients. The second is to test feasibility of implementing these models in a variety of oncology practice settings, especially those serving the underserved populations. The third goal is to test the effectiveness of these models and their components. The fourth is to evaluate the sustainability and scalability of these models. For the companion program announcement, which is asking for R21s, The first two goals are the same. The third goal is asking to test the usability and potential effectiveness of the IT-specific components of these new delivery models in an oncology practice setting. The scope of the funding opportunity announcement, in this slide, I'll be describing the different elements that are of interest to us. The first is oncology practice settings. All oncology practice settings, be they in academic cancer centers, community cancer centers, or oncology practices, surgical oncology, medical oncology, radiation oncology, any one of them and all of them are within the scope of the FOA. The second is that we are supporting the use of established evidence-based screening and diagnostic instruments for depression and also established efficacious treatments. So we are not asking for new ways to screen for depression, new ways to diagnose depression, or new ways to treat depression. We are asking for better integration of existing tools that we have to improve depression management in cancer care. The third element is to support the use of appropriate mix of qualitative and quantitative methods to evaluate the effectiveness of the new delivery models. The next are the outcomes. The outcomes of the patient, the provider, and the system level are all of interest. For example, improvement in depression, improvement in adherence, improvement in communication, satisfaction, timeliness, reducing costs. All of these outcomes and related outcomes are of interest to us. We are also encouraging research on sustainability and scalability of these new IT-based delivery models. For those who are designing the information technology, one has to consider several different elements, and we are encouraging the use of human-centered design principles. The user in this case may be either a single clinician, a team of clinicians, a patient or the caregiver of the patient, or a combination of these users. For anyone designing the new IT-based delivery model, it is helpful to understand the clinical workflow and the clinical needs relevant to depression care in oncology practice before designing the delivery model. One should also consider the sustainability and the scalability of the IT-enabled delivery model before you go ahead and design the model. The other element of information technology is that it can be used in several different roles. It can be used to support communication between clinicians or between the clinicians and their patients and the caregivers. It can be used to improve the care coordination. It can be used to support depression screening and treatment, or either one of those. It can be used to collect and analyze data, and it can be used to present data for decision support. Additional considerations for information technology are to use available standards and existing best practices to ensure that we can improve the interoperability of the data needed to deliver the intervention, to protect the patient's privacy, and especially paying attention to the HIPAA regulations, and ensuring compatibility with an existing oncology practice or other care delivery organizations' cybersecurity protocols. To do all of that, the researchers will need to assemble multidisciplinary research teams that can be composed of many different disciplines, for example, information technology experts, clinicians, whether they're oncologists, nurses, social workers, or primary care physicians, psychiatrists, psychologists, so a variety of clinicians here, human factor engineers, communication scientists, or clinical epidemiologists, and any other relevant disciplines. I would encourage you to read the FOA very carefully. Since this is a program announcement, the standard dates apply. The earliest due date for these program announcement is June 5th, 2018 for the R01, June 16th, 2018 for the R21. The earliest project start date would be April of 2019. The PA expires on May 8th for the R01s on 2021 and May 16th, 2021 for the R21s. Please start the process early. Allow enough time for registration in the system for award management, ERA Commons, and grants.gov. The resources that you will have will be today's webinar and an FAQ that will be posted on our website. The link is given below. Please connect with me early in the start of the application process. Check the FOA for more details and the listing of our staff. Please stay connected with all of us. We have both an email listserv. Please sign up. The link is on our homepage. And you can also follow us on Twitter. Both the links are given on the slide. So now I will move on to the Q&A phase. And while you are typing your questions, I will start out by answering several questions that have already come in. And while you're listening to this, if you have additional questions that are not answered, please feel free to type them now. Or if you don't do it now, I'm happy to respond to them later. So the first question is, I am working on new approaches to detect depression. Will that research be supported by this FOA? So the answer is that the intent of the FOA is to identify new IT-enabled delivery models that integrate established instruments to screen and diagnose depression. Therefore, new approaches to integrate these instruments in care delivery are within the scope, but new approaches to screen or diagnose depression are not within the scope. Second question, do you see a place for smartphone-based screening and follow-up? Yes, smartphone-based screening and follow-up is within the scope and is encouraged by this FOA. Third question, is there an interest in looking at the development of novel mobile treatment technology, for example, apps, standard technologies, internet-based or telephone, or a comparison among face-to-face, video telephonic, internet app-based treatments? The answer is both new technology development as well as existing technologies to better integrate established treatments in oncology care are within the scope. Comparison of the effectiveness of different technologies to treat depression is also within the scope of the FOA. Question 4. Is an intervention app or online treatment tool that has already been tested and found effective in depressed patients, but not in a population with cancer, would this be an acceptable idea for the R01 funding mechanism? Yes. Any proven IT-based tool that has been tested in other patients with depression who don't have cancer, and that research hasn't been done in cancer patients, is within the scope of this FOA. Question 5. Do interventions delivered via social media fall under the scope of this FOA? Yes, the interventions delivered via social media are within the scope, but please remember, the use of information technology should ensure protection of patient privacy and compatibility with the cybersecurity protocols of the oncology practice. Question 6. I plan to work with rural serving oncologists who would refer patients with depression to a telehealth-based cognitive behavioral therapy intervention. Does this qualify as an IT-enabled delivery model under this PA? So from this question, it is not clear whether the intervention that is being proposed closes the loop after the referral so that the referring oncologist knows the outcome of the referral and the need to make any changes to the patient's treatment plan. Please remember the new delivery model needs to be well integrated in the oncology practice. Question 7. I want to use claims databases to identify cancer patients with depression and evaluate a new delivery model to treat these patients. Is that within the scope? Answer. It is not clear how well this new delivery model will be integrated within the oncology practice. If it is well integrated, then it is within the scope. Question 8. Does this FOA support research on web-based cognitive behavioral therapy for treating cancer patients with depression and for other psychological problems such as anxiety? The intent of the FOA is to support IT-based interventions to treat depression. If the case can be made that extending the treatment to other psychological disorders will help in the sustainability or scalability of the delivery model, and that by doing so one does not detract from the main goal of treating depression, then this would be within the scope of the FOA. Question 9. How remote should the interventions be in terms of the scale of the study? For example, should proposals include a large-scale study of many cancer centers to see if mobile tech is viable at scale, or local with a more in-depth assessment of patient outcomes, e.g. in person? Answer. It is important to first establish the effectiveness of the IT-enabled delivery model in oncology practices before scaling it up. If an effective IT-based delivery model is already being used in one or more cancer centers, then a large-scale study of several cancer centers within the constraints of an R01 mechanism is within the scope. Question 10. Are you looking for us to leverage existing platforms or technologies, or to develop new technologies for this funding announcement? Answer. Both approaches are acceptable and within the scope of the FOA. Question 11. Is there an interest in including assessments beyond the self-report measures mentioned in the FOA? Would there be interest in other assessments such as cognitive assessments, EMA, etc.? Answer. The intent of the FOA is to show effectiveness of the care delivery model in treating depression and demonstrating that it improves outcomes in care delivery. The care delivery outcomes can be at the patient level, such as medication adherence, at the provider level, such as provider satisfaction with the new delivery model, improving communication and coordination among the providers, or at the system level. Examples of these outcomes are given within the example research questions of the FOA. We are not encouraging research to go much more in depth about cognitive assessments or other patient-level outcomes. So those were the questions that were already in our list of questions to answer. Now I'll be responding to 2 more questions. The first question is this FOA interested in cancer patients or cancer survivors, or both? So anyone who has a diagnosis of cancer and has depression is within the scope of this FOA, be it a new cancer patient with a new cancer diagnosis or a cancer survivor with a pre-existing diagnosis of depression who has been a survivor of several years. So we are open to anyone with a diagnosis of cancer and depression. That's within the scope. There's a question about multiple PIs for an R21. I'll have to check on the prerequisites for that. I don't believe the R21 mechanism allows for multiple PIs, but I will get back to you in the FAQ. That is the end of all the Q&As that we have received. I can give you another minute or 2 to think about other Q&As. Otherwise, we will wrap this webinar up. Okay, so we don't see anyone typing furiously, so hopefully we've answered your initial list of questions. We'll wrap up this webinar, and even though we are wrapping it up, please feel free to contact me down the road if you have any questions. With that, I'll turn it over to Jennifer.
Thank you, Dr. Rundhalba. And as was mentioned, if you have any additional questions following today's presentation, please feel free to reach out to us, and we'll be happy to answer those following today's webinar, and definitely use this as a research, as the FAQs from today's presentation will be posted online within the next few weeks. Please feel free to continue the conversation, and we greatly appreciate your feedback by filling out the survey that will appear when you exit WebEx. Thank you again for your participation.